Well, thank you so much, Tenor, and welcome to session 3. My name is Jill Morgan. I'm a critical care nurse from Emory University Hospital, and I will be moderating this next session. In our conversation today, we're going to spend some time reviewing and examining what happened during COVID as a means of learning from both the failures and the successes. I'm grateful to Linda for her earlier reminder that lives have been changed and lost. We are going to look across the supply chain to understand how standards impact production, distribution, and the use of PPE. We're going to talk about PPE access and use by healthcare workers, other critical infrastructure workers who may not have realized they would ever have a need for PPE, and of course, our newest users, the general public. We have a really interesting panel representing a wide range of PPE supply chain experiences, including manufacturers, distribution people, and then end users. I will be inviting, as Tenor did, each speaker to share their remarks for about 5 minutes. And then once they're all completed, we'll have a question and answer period. So please be thinking about questions in advance, and you can enter those in the Q&A function at the bottom of your screen. If you'd like more information about any of the panelists, there is a link to their bios that's been posted on our event webpage. So thank you very much. And from the manufacturer's point of view, we're going to start with Nikki McCullough, who is the Vice President of Global Application Engineering and Regulation for the Personal Protective Division at 3M. Thank you so much for joining us, Nikki. You are up first.
Thank you so much. I am trying to get my video to start, but can you hear me okay?
We can.
Okay.
No worries. There you go. We can see you now too.
Thank you. My name is Nikki Vars-McCullough. I work at 3M. I have been here for 26 years. Prior to that, I was at the University of Minnesota under Dr. Lisa Berceau, where I studied airborne infectious diseases and controlling them through the use of respiratory protection. I'm going to make some opening comments this morning based on my experience with 3M as a manufacturer of PPE. First, I'd like to thank the National Academies for this session and for inviting me to speak. Throughout my talk, I'll be using the term respirator, and just to make sure that you understand what I'm talking about NIOSH approved or government approved devices designed to reduce your exposure to airborne particles. So I'm not referring to masks or other unapproved devices. As you know, early in 2020, we saw an unprecedented spike in demand for personal protective equipment, N95 respirators in particular. Part of this is because we saw the spread of disease and we had no vaccinations. But some of the other contributing factors were that many organizations, both industrial and healthcare, did not have safety stocks of personal protective equipment. The Strategic National Stockpile had products that were past their shelf life, which resulted in a lot of questions about usability. And we had use patterns really sporadic across different organizations, because some organizations in healthcare were throwing away respirators after every patient visit, but some were already instituting reuse practices or extended use practices. As a manufacturer, we do have a lot of manufacturing here in the US. We have a regional manufacturing strategy that has been in place since the 1970s, which means that we manufacture our personal protective equipment as best we can in the areas where we're going to supply it. So in the US, we have manufacturing in the Midwest, mainly in the Midwest, of N95 respirators to supply our US population. In Europe, we have manufacturing in Europe, also in China, Asia, and Latin America. But some of the challenges, even with a large manufacturing base here in the US, are our just-in-time economy. So we don't necessarily have huge amounts of inventory, neither do our suppliers, or our suppliers' suppliers are our suppliers' suppliers. So as we very early in January even went to move to turn our factory to 24/7, from a more normal shift work, the first thing we had to do was notify all of our suppliers down the stream that we needed significant more raw materials. And then we had to hire a lot of people immediately in the towns in which we did manufacturing, and so did our suppliers. So even with huge, with a lot of capacity, we still had some time to ramp up to our full capacity of manufacturing. And then we were able to extend manufacturing throughout the United States to increase our capacity further. Some of the reasons that we were able to do that so quickly, not only ramp up our current existing production machines, but build new ones, was because of the strong NIOSH regulation. NIOSH, as part of the performance standard of 42 CFR 84 respirators, does incorporate quality plans. So they monitor your quality plans, your user instructions, your packaging. That is very important, and it is different than many other respirator performance schemes around the world. But by already having all of those in place, we were very easily able to expand our production. NIOSH also worked with us very closely, as they did the other manufacturers, to set their priorities internally so that respirators for the pandemic were given high priority. And they were able to quickly work with us if we needed to extend approvals due to raw material changes, a headband change, or where we needed to bring new capacity online. Some of the other things that really contributed to being able to deal with the situation was the healthcare response. Many healthcare institutions had dealt with H1N1 or gotten prepared for Ebola, and so they understood the role that general use respirators, reusable respirators, and powered air purifying respirators could play in their response to this. They also had documents available from OSHA and NIOSH. There's a joint Department of Labor and Health and Human Services publication, a respirator protection toolkit for healthcare, which was a great guide to help people through that. Some of the other things that we did to help address the pandemic were to stand up a fraud and counterfeit hotline. There was a lot of questions about respirator N95 in particular, counterfeit products or fraudulent offers. If you were on the internet, you probably saw that people were offering all sorts of things. So we stood up teams and hotlines and websites in every area of the world, including the US, and actively worked with distributors and end users to help them identify if product was authentic or if it was fraudulent. And then we have been prosecuting those offering fraudulent offers or counterfeit products. As I mentioned, we feel the NIOSH standard, the OSHA standards were really robust standards. But looking forward, I think that the standards incorporating fit into the filtering face piece standards, the N95 standards of NIOSH, would be a great benefit to help ensure that respirators available to the working population do fit at least a portion of the population. There is fit incorporated into reusable respirators, but it would be beneficial to have that further incorporated into filtering face pieces. Additionally, it would be, as mentioned earlier in the webinar, very helpful to have standards available for respirators designated for the general public, and particularly for elementary aged school children whose faces are smaller than might typically fit in most respirators designed for adults. And another standard that would be helpful would be to have a more robust way to evaluate respirators approved in other countries, such as Europe, China, Korea, evaluate their suitability for the US population, particularly with regards to fit. And the last thing I'd like to address in my opening comments is really around the conflicting guidance or the changing guidance. Most of that guidance was really focused on healthcare. And I think that caused a lot of confusion for non-healthcare workplaces, but also for the general public. And as a manufacturer, with a technical helpline here in the US that is available to answer questions from anyone, staffed with people trained in occupational safety and health, our call volume spiked as much as our respirator demand spiked, with people trying to understand the guidance. And so I think that, looking forward, having clearer guidance, having it more accessible, understanding what is changing, and having guidance not just focused on healthcare, but focused on other occupations and on the public, on other community aspects would be incredibly valuable. Again, thank you so much for inviting me to be a part of this panel, and I look forward to hearing from our other speakers.
Thank you so much, Nikki. All right, from distribution, our next speaker is Susan Gorman. She is the Associate Director for Science with ASPR and the Strategic National Stockpile. Thanks, Susan.
Okay, how about that? Thank you very much for having me. As others have mentioned at the start of COVID, there was a limited supply of PPE in the Strategic National Stockpile. And that PPE was also older and had been purchased about a decade earlier during the pandemic influenza event. But we had continued to hold on to it because we were working with NIOSH, who was looking into the viability of older PPE that had been stored in a number of different environmental conditions, but also for different lengths of time. And that was a 3-year study, and the data that they derived from that study culminated right at about the time that the COVID response was taking off. So that was very serendipitous, and it allowed us to use some of the PPE under certain conditions that was older and had expired. We were able to convey that message to the jurisdictions that received this PPE from the stockpile through both a Dear Healthcare Provider letter, but also we held a series of phone calls with each jurisdiction that received it to let them know this was older, expired PPE, had been evaluated by NIOSH, and to let them know the different conditions under which it could and could not be used, and also the fact that they would need to inspect the PPE before they used it to make sure it did not look damaged or anything like that. So if we hadn't been able to use that old PPE we had in the stockpile at the time, we would have started out the response with really nothing available to send out to our state and local partners. Historically, the stockpile has only been able to procure large amounts of PPE with supplemental funding during the actual emergencies, such as the pandemic influenza event in a decade ago, but also a little bit during the Ebola outbreak in 2014 and 2015, and then again with supplemental funding during the COVID event. Some of the items that we had in the stockpile had expiration dates assigned to them, and then there are other PPE items that did not have expiration dates or are not required to have expiration dates. So that played an important role for us, and will again play an important role as we have massively stockpiled PPE now that COVID is winding down, and all of those products either have an expiration date or a lack of a date. But those things are helpful to us in determining when we need to budget to try to replenish these PPE items, assuming that funding is available. But it also can guide us for how long past an expiration date we may want to consider holding on to items if we don't receive funding to replace them. These are very bulky items. We have hundreds of millions of items in the stockpile now, and they are expensive to store and warehouse and maintain. So we want to be able to strike a balance between how long we could potentially viably use these products and how long to stockpile them or store them or not, because that space could be freed up for other things and the money could be freed up to buy additional products as well. Historically, the stockpile has PPE set aside for healthcare workers. We don't generally stockpile PPE for the general public. I say that, however, we had probably the largest distribution of PPE in the United States in early 2022 with a presidential directive to send out N95 respirators to the general public. We made about 250 million N95 respirators available through pharmacies and also through federally qualified healthcare centers. We have a variety of different types of PPE in the stockpile, as well as a variety of sizes of the PPE. And we sent out the initial items in a pro rata distribution. So based on the population of a project area or jurisdiction, they received a portion of the PPE that we were holding. This was somewhat difficult because they may not have received the exact products that they are used to using. They may not have received N95 respirators that they had fit tested to. So they were getting other products that they would have to fit test to or become familiar with. because we were supplying for all across America and not a localized event, we tried to equitably distribute the different sizes and the different products to each of the project areas. This also was a little bit daunting to us when we had to interpret what a size small was versus a size medium versus a regular versus a medium large, and make sure that those were all allocated equitably. So these were a couple examples of how standards surrounding expiration dates or lack of expiration dates and the various sizing would help us going forward as well with stockpiling. Also, we were trying to procure PPE for all of the United States at the same time. Everyone in the world was trying to procure the same PPE. So we were reviewing the standards, reviewing PPE products that were on the market that we were less familiar with from maybe brands that we hadn't had as much experience with in the past, and trying to ensure that they met the standards as we knew them. That was difficult to do during an emergency. And also people were ordering everything they could get their hands on, and some of those products ultimately did not meet the standards as we know them, or even were counterfeit, as others mentioned in previous sessions. So that, I'll turn it back over to you, Jill. Those are some of the things we ran into with stockpiling during COVID-19, and I appreciate your time. Thank you.
Thank you so much, Susan. All right, our next speakers are John Fleming and Corey Warden from the Houston Health Department, where John is the Public Health Preparedness Bureau Chief for the Houston Health Department, and Corey is a Safety Advisor for the Houston Health Department. Thanks, guys.
Well, thank you so much for inviting us. I'm going to let Corey lead here with his slide deck, and I'll provide a few comments at the end. Go ahead, Corey.
Great, thank you. Well, again, also, I appreciate the invite. Always glad to talk to everybody. What I'm going to do is give a very macro level overview of some of the things that we've encountered over the last several years, in particular from the safety management side. So you'll see on this first slide here, this shows a microcosm of a safety management system. And this is the first thing I wanted to mention, because this provides the framework to ensure that we're able to adapt to the situation as it changes, which I know has been being discussed over the last several minutes. A lot of different variables come up, whether it be changes in the research about the pathogen, or whether it's logistics, availability of respirators that causes different changes in fit testing requirements and things of that nature. So there's a lot of factors. So if we don't have this dynamic safety management system, there's a pretty decent chance that we'll miss something which could have residual hazards along the way. So that could actually make the situation worse. On the next slide, you'll notice, let me see. Oh, there you go. Thank you. This shows how that ties into the high reliability principles. So everybody, especially from the healthcare environment, I'm pretty certain you've heard of this and probably worked with it if you're doing Joint Commission and things like that. So you'll notice here how that safety management system along the bottom is what enables those high reliability principles. And of course, high reliability was created as the precursor to making sure that we're able to prevent potentially catastrophic outcomes with operations that have the potential for that. So as we see here, those have very direct correlations. So if we're able to do a proper hazard analysis and proper hazard control planning, then by definition, we're going to be preoccupied with failure. We're going to defer to experts. We want to make sure we're not oversimplifying things. We want to make sure that we're putting in the most effective controls. And then, of course, we're following up when there's any type of negative outcome. And so what this does is it allows us to continually improve. So the big thing about that is that that's going to enable us to catch when those things change, such as, again, changes in the pathogen, changes in the logistics trail, things of that nature. Next slide, please. So the reason that's important here is when we're talking about any type of CBRN response, which of course, a lot of times CBRN gets looked at in the perspective of like a chemical warfare agent, but we're talking about a biological hazard and just happen to be naturally occurring. So as you see here, there's 5 big things that have to happen in a CBRN response. And so within that, we want to make sure that we know what the hazard is. We want to make sure we know all the characteristics so we can communicate that properly, make sure we know what to do to stop the spread. And then we want to make sure that responders are protected. Then we want to make sure we know how far the thing has spread. So in this case, we'll be doing contact tracing and epidemiology. And then we want to do recovery, which in this case would be like vaccinations and medical treatment. So the big thing here is that if we're not able to properly do these 5 components, then again, we're going to potentially miss something that could have a lot of residual negative outcomes. So for example, if we're not able to properly communicate, then we have a much harder time promoting things like source control and things like social distancing. If we can't explain and articulate how to stop the spread, then again, we're going to have trouble with things like source control and social distancing and things like quarantine and isolation. And then as far as the responder protection, that's what we're talking about here today, is that if we're not able to get a proper logistics trail, then we have issues with things like price gouging and counterfeiting and supply storage shelf lives and dry rotting and a lot of different factors there. So ultimately, we want to make sure that all of these things are secure so that we can make sure that the response can happen, which is going to help to prevent it from worsening or having any kind of residual hazards. Next slide, please. And this is the last thing I was going to cover. Like I said, I'm being very expedient about it, but if anybody would like any further information, feel free to reach out. I'm always happy to talk more. I can send you any of the resources we have, any of our different models, any of the case studies, checklists, any of the resources. We're very transparent. And so you'll see here, the reason this is so important is if we're talking about risk management, it all boils down to frequency and severity. So you'll see there at the bottom, the employee safety issues, which would be things like respiratory protection for the responders. Those are going to be things that happen on a very frequent basis. If you're talking about a hospital, anytime they go in an isolation room, they're dealing with respiratory protection. If you're talking about public health, our epidemiologists are always dealing with respiratory protection. And the reason I say that's the lowest severity, though, is because if you have an exposure to an employee, it's very severe for that individual employee, but it's not necessarily going to stop any operations. Like, it's not going to shut a hospital down. But that being said, if we don't handle it appropriately, then you'll see there we get up to either a campus safety or a area or community safety issue, and that increases the severity. It's less frequent, but it's more severe because now we're not only talking about employees, but we're also talking about the potential for things like the precedent for an outbreak or litigation or things of that nature. So if we still don't handle it properly, then it goes up another notch. Now we have an infection control issue, which is going to affect the community. And so in that case, the frequency is much lower, but now the severity is that much higher because it's affecting a lot more people and it has the potential to spread. And then lastly, if we still don't handle it properly, then it goes up to the lowest frequency, but the highest severity, which is the full-on emergency management construct with NIMS and ICS. And that's what happened with COVID-19, is that it went from being an issue about respiratory protection and isolation rooms, and it went all the way up to shutting down the entire world's economy in a very short time. So the more we're able to do with hazard controls, then the more we're able to prevent these type of situations from worsening. And so the last thing I'll leave with is that we're talking about PPE, but if we're doing safety management properly, like we showed there in the first couple slides, then we're able to identify when it's possible to do things like physical separation, things like mechanical ventilation, or moving things outside so we have natural aeration, or if we're doing social distancing and source control with hand hygiene and disinfection. All of those things are equally effective. So for all those people, which amounts to a lot of people that don't have to be in the direct hazard area, generally meaning within 6 feet of somebody who's potentially infectious, then we can utilize all those higher level controls, the elimination, substitution. Elimination is not really possible, but substitution, engineering, administrative controls. And then for the people that absolutely have to be in the hazard area, then we can apply the PPE, and that's going to help with the logistics, because we're not talking about that may be the difference between talking about billions of N95s versus millions, something of that nature. And then we can also look at things like peppers and all the different potential alternatives. So there's a lot of opportunity there, and we're always happy to help with any solutions, and always happy to talk more. So I appreciate y'all's time, and I'm going to pass it to John. Thank you.
Thanks, Corey. So the other thing I wanted to add is when we're looking at the the actual maintenance of local caches of PPE. Been in this business since the early 2000s. We started off planning for H5N1 influenza pandemic and started more or less hoarding these N95 masks and fell into that trap that was alluded to earlier, that we primarily looked at protecting healthcare workers and our staff, and not how are we going to address the needs of the community. So we didn't have a big cache of masks that could be used for the community. But also, we didn't recognize the investment it would take to really monitor that. So we had, a fair bit of waste from that first round of cache that was established for H5N1 that we, didn't learn how bad it was until 2009 with the H1N1 pandemic, and realized we had a lot of masks that had deteriorated then. And then we went through that again with COVID, that we had stores of these, particularly N95 respirators, that had really perished. And then changes in the standards, like we had a lot of stuff that didn't have expiration dates. And now, of course, everything we have that's been recently purchased has expiration dates. And that poses new problems. We can do inspections and viability testing on these masks now that most are actually past their expiration dates, and that puts us in another quandary. Can we continue to get guidance on using equipment that's past its expiration date? But this really points to a lot of issues on trying to maintain these inordinate size caches to be able to respond to these surging needs when we do have pandemic episodes. And I'm not sure what the answer is, but clearly the guidance has changed. I remember back in the day before we had the National Pharmaceutical Stockpile and the SNS, there was a lot of emphasis for locals to develop these types of caches and caches for antibiotics as well. As the National Pharmaceutical Stockpile evolved to the SNS, a lot of that stress on maintaining local caches really switched to, we're going to be okay because the federal government has this well in hand through the SNS, and it looks like now we're having to reassess that. Is that the best model? Is a state model the best model, or should we indeed be investing in this at the local level? And how do we determine what is the right quantity to have? So I'm sorry, I have more questions than I have answers for. I just thought I would share some of those concerns. But certainly the logistics of maintaining those types of caches gets very involved, not the least of which is making sure that you have the right models for your workforce. So of course, we need to find ways to integrate our fit testing data with our actual caches, and make sure we're stockpiling the right mass, and that might change with our workforce. That's all I have. Thank you.
Yeah, thank you so much, John. It's a great perspective that you and Corey bring to this. Our next speaker is Sean Keiss from the Tennessee Strategic National Stockpile and the Tennessee Department of Health. Thanks, Sean.
Hello, everyone. So standards have been my friend for quite a long time. Big fan of 29 CFR 1910-120 as we move forward with this. And so because of that, pre-COVID, I've put a lot of our PPE into 10 large buckets that we have to deal with on this, starting with a baseline of standard and transmission-based precautions, the 2007 guidelines that were then reaffirmed in 2019, as our base level that we're going to use to respond to our general healthcare response. So I'm not talking about on-field or at scene hazmat response, going to stick with the healthcare side of this. But even looking at things that happened, say yesterday, I had to send a health alert network out for a measles response. So that puts us inside another bucket, whereas the CDC says that now I have to go above standard precautions and move to N95 respirators, regardless of evidence of immunity. And I'll say the week before, we had a site area emergency at a national lab, which puts us into a radioactive response on this. And so at that point, I have to follow a standard, also inside the U.S. Department of Health and Human Services, but the Radiation Emergency Medical Management side, which then tells me that I need a P100 full face respirator for my respiratory protection. And so that is a standard above that many healthcare facilities have on it. And so if we look at other things that we have inside of Tennessee, we have a lot of fentanyl response these days as part of the opioid crisis, but that puts us at a minimum level of respiratory protection that we need at a N100, which puts it at a, stresses our particular aspect of being able to cache and maintain a PPE stockpile of having multitudes of different kinds of small respirators across the board to ensure that we can meet the needs that we have. And then complicating something, if we were to look at, say, we had Ebola raise its ugly head earlier, at that point, while respiratory protection may not be the highest of complications on that, we then have to move into the fabric standards that we have to deal with. So wet patients, we have to follow an ASTM F1671 or the ISO 16604 for artificial blood penetration. But then we have to have those same standards that go along with seams. And so explanations of how healthcare should wear their PPE can go across the board and cross many different agencies that are requiring our PPE standardization. So we do not have a single location across the board in the United States where we can go and look for our PPE requirements to meet all of the scenarios where we may have to respond. And rolling into COVID-19 on this, after the emergency use authorization for foreign respirators was introduced, we'd have to go and explain to a lot of healthcare facilities that just because it says a KN95 on it does not mean that it meets the EUA standard on this, because there were 3 different KN95 standards that were currently implemented at that time: the GB 2626, the GBT 32610, both of which were not medical standards. It was only until you moved into the GB 19083-2010 did you find a medical standard. And so if it's hard enough for me to go through all those numbers right now as I was reading it off of my computer screen, imagine what it was going for people who aren't used to dealing with that. And so we'd have to go and separate whatever PPE was purchased for us and put into, this is a bucket that can be used by healthcare, or this is a bucket that we have to move to our other customer, which is the general public. The general public was a very large customer of ours. When we had to explain to them a lot of times about the hierarchy of PPE, saying that we need to use this medical PPE specifically for our nurses and doctors who cannot move away from a COVID patient. But a general person, the general public, has the opportunity to evacuate themselves from a situation. And so they do not need a respiratory protection factor that is as high as a medical provider dealing with active COVID patients. And so we were able to show them that even though you may have a European respirator, just because it says FFP on it does not mean it's a medical one. The FFP3 is, but the FFP2 and FFP1 are not. And that's one of the things that put the United States at a disadvantage, as was brought up in the earlier segment, was that we did not have a lot of general public standards that were already created. During COVID, CDC created a couple of new standards on this: the workplace performance and workplace performance plus that we see, along with the ASTM F3502 and one that was brought up earlier, the F3505, I believe, both of which met the needs of the general public because they were not near active COVID sickness all the general time. And one of the aspects we have on this was that the CDC and the July 9th, 2021 issue of Morbidity and Mortality Weekly Report, the MMWR, had very solid scientific evidence showing that even respiratory protection without a standard, such as the Haynes cotton masks, where Hanes moved from making underwear into making masks to be distributed by FEMA on this, met a level that was acceptable to the general public, meaning that it would be generally equivalent to having a consumer grade HEPA filter inside of a room aside with you, as long as everyone participated in universal masking. And so we were able to show scientifically that some of these standards that were not up to NIOSH in 95 were absolutely acceptable. And so as we explained to the public, who was one of our major customers, was that they did not need the medical standard. It freed up a lot of PPE that we could then push towards hospitals on this, and really, really reducing the strain on our own internal supply chain that we had on. So thank you very much for having a couple minutes to talk about this.
Thank you so much, Sean. All right, next we have Daniel Gerard, who's from the International Association of EMS Chiefs. Thanks, Daniel.
Thank you for having me today. My name is Dan Gerard, and I'm the president of the International Association of EMS Chiefs. I'm a paramedic and a registered nurse, so I spend a lot of time arguing with myself. In the US, EMS is the healthcare provider of last resort for the socially and economically disenfranchised, the canary in the coal mine and the tip of the spear for major incidents. During the pandemic, acquisition of PPE was a challenge, even on our best days. Changes in how EMS managed their medical supply changed the operational dynamic. Prior to COVID, many EMS organizations had transitioned to just-in-time stocking, mirroring what was occurring in the healthcare systems. Pre-pandemic, few organizations had more than a 14 to 30-day supply of PPE on hand. Calculations for utilizations rates were stunted by a variety of factors. First, there was no experience pre-pandemic of what we should expect regarding day-to-day needs during the height of COVID. For N95 mask, utilization calculations could not be calculated effectively due to whether or not we used an N95 mask one time as they were intended, or whether we reused them multiple times. It made the extrapolation of PPE usage impossible to apply to other locales. We were and still are at the mercy of foreign producers of PPE. The competition between EMS and everyone else who required PPE created a Lord of the Flies scenario. Hospitals and healthcare systems received first priority for all PPE. Orders placed for masks were embargoed on arrival in the US, redistributed to hospitals, and never made it to EMS. Requests were backlogged up to 2 years. This was not only limited to masks. Everything we required was in short supply and made us resort to crisis standards of care. The price of gloves, for example, skyrocketed from $8 per box to $35 per box. In an attempt to address the issues surrounding N95 masks, one state secured a contract to supply EMS and healthcare providers with N95 masks. These masks were purchased overseas and had a 40% failure rate. This is not a criticism of that state. Instead, they should be applauded for their efforts, but it highlights the hurdles that were almost impossible to overcome in the midst of the pandemic. The EMS environment is demanding and unforgiving. If you are extricating a patient from inside a car and it is raining outside, there is no way to protect your PPE from getting wet. Doffing and donning out on the sidewalk or along a highway, and temperature extremes as varied as 5 below zero to as much as 104 degrees Fahrenheit are further complicated by wind, rain, and snow. You cannot doff and don inside the ambulance. The patient compartment presents a risk of exposure, and you will contaminate the driver's cab, the area considered safe if you attempt to doff your gear in the cab. Single-use, single-patient masks are cheap and easier to use, but are not meant for long-term use, nor do they lend themselves to the unforgiving environment EMS operates under. Motor vehicle collisions, shootings, and cardiac arrests, the very essence of the scenes we operate at, are not controlled. not like the hospital or skilled nursing facility environments. Aerosol generating procedures, CPAP, nebulized medications, suctioning, intubation, all occur in enclosed spaces with poor ventilation, increasing the chance of exposure. Elastomeric half-face respirators are better, more durable, but have many problems. One being they increase the heat burden on those wearing them. Patient communication is impossible, and they are bulky. The gowns that were provided for EMS were not meant to be used in the field, and spun paper suits, while offering better protection, again, increase the heat burden of those wearing them, increasing fatigue. Reuse and decontamination of PPE was a fool's errand. Frequently, EMS wore the same single-use, single-patient spun cellulose polypropylene fiber masks for 8, 12, and 16 hours at a time. These masks should have been discarded at the end of the shift, but instead they were stored and were worn again in the same demanding condition. Continued use made them harder to achieve a fit that would provide the protection required for use. Elastic head straps would stretch out, the foam padding across the bridge of your nose would be compressed, and the metallic wire would deform. Decontamination processes, regardless of type, may have destroyed the COVID virus on the outside of the mask, but they degraded the mask's ability to provide protection. Decontamination processes broke down the mask fibers, allowing the penetration of bacteria and viruses. After decontamination, it was harder to achieve a good fit with the mask. Worse, decontamination destroyed the electrostatic charge on the mask that was essential to ensuring protection from the viruses. Thank you for having me today, and I look forward to taking questions later. Thank you.
Thank you so much, Dan. All right. Last is Jennifer Kiger from the Houston-Harris County Public Health Department, where she is the director of the COVID-19 division. Thanks, Jennifer.
Thank you, Jill. I know I think we're a little bit over time, so I'll go ahead and be brief, hopefully, with this. But yes, my name is Jennifer Kiger, and I work with Harris County Public Health. It's great to see John Fleming on here with City of Houston Health Department. We work very closely together for the last couple of years. So for public health, our role with PPE during COVID-19 was really guidance to the public, and then also surge support in providing PPE to healthcare providers, including long-term care facilities and hospitals when needed. Also providing them guidance on how to use PPE and what PPE to use. For our health department, we struggled with finding PPE just like others have, whether it was for our own operations of vaccination or testing, or to support hospitals and vulnerable populations. We were often asked to provide PPE to these vulnerable populations, and as it was mentioned before, it was often difficult to find that and reliable PPE. In our health department, and I'm sure others would probably agree, we have a lot of administrative barriers, even within emergency situations, where procurement and finding that reliable PPE was a struggle, whether or not we had to go through RFP process or have POs. And also competing with other agencies across the nation, where often it resulted in going to the highest bidder. And when we are utilizing PPE for our testing, our vaccination sites, sometimes the federal government would provide us with shipments of PPE, which was very helpful, especially when we were doing our mass vaccination sites, vaccinating at close to 10,000 a day, or our test sites in the beginning of COVID-19. We often had storage issues with, we would store those PPE caches on site, and we'd had to have 24/7 security. And even with that, we had several shipments, leave the perimeter. Additionally, we would share with our locals in the regional area who maybe didn't have that ability to be the highest bidder for these PPE cache requirements. And then we had to pause some of our testing and vaccinations sites and those resources to the public, because the shipments were either delayed, either from the federal government or for the companies that would promise us to get PPE in a timely manner. Additionally, we would use our PPE for up to 5 days in a row, which caused concern for our staff and sometimes the public, because that wasn't the norm that we would do in the past. Where we would hold them in plastic bags, and when staff came back the next day, they would use it again. And that's just what we had to do because we didn't have enough PPE. I know the presenter before me talked about weather conditions here in Texas. We have very hot summers, and we also had an ice storm where we had no power, but that also made us utilize more PPE than normal, because in the hot summer, they were sweating through their PPE, which made it no longer sanitary. We got some innovative ideas in utilizing 3D printers to create some PPE. But additionally, the communication to the public was often difficult with all the changes. Communicating that to other healthcare workers or even to the public on what masks they should use, or even if they should use them at all, which often led to lost in trust from the community to our health department because of that changing in guidance. The other thing is trying to balance what PPE people should use and what that meant in affecting the PPE that our healthcare partners had access to, especially when there was shortage across the area and across the nation. So high level, that's what I wanted to talk about today. And thank you for inviting me to speak.
Thank you so much, Jennifer. And if we could have all of our panelists come on, we're going to try to get a few questions in. I know we are a little bit over time, but we've got several questions that I think we'd really like to hit on. First, I want to thank you guys so much also for highlighting the importance of the hierarchy of controls and the other things that we can put in place that can help us with the decreasing the need overall for PPE, understanding that that is the last portion of the hierarchy of controls. So I think that's really just such an important piece to get in there. I know I struggle with coming up with positive steps forward, because for many of us, and I certainly heard the emotion in some of your voices about how hard this was and how difficult it was, and how we felt like maybe we were failing our coworkers and our teammates and the general public that might be in our care. So what I want to ask generally, what we think we can do moving forward that will actually play a role in making the next situation better. Whatever that situation is, if it calls for PPE, how do we make sure we're going to be better prepared? And I think that it's important to think about whether that's something that requires respiratory protection or some other form of protection, right? Some other device or application of PPE. So just come off mute and let's have a conversation about that. And then I've got several other questions I want to ask. So please.
Well, I'll start as a manufacturer. I think a couple of the things that we could do would be looking at how do we keep the manufacturing base alive during times of low demand. As I mentioned, things like surgical N95s typically have very low demand in 2018, 2019, very low demand. And then we saw a couple of years of super high demand. Given our economy, if no one is buying them at all, or there's or they're very, very low percentage of purchasing, as a manufacturer, it just isn't economically feasible to keep making, hundreds of millions and putting them in warehouses, right? I think, so thinking of warm manufacturing and certainly thinking about stockpile management. How do we keep products flowing through stockpiles so that we aren't talking about products that have passed their shelf life and then therefore are no longer NIOSH approved? Once it's no longer NIOSH approved, I can't reapprove it for you. So how do we keep those stockpiles active and moving, which also means you're keeping the manufacturers at least with some knowledge of manufacturing that products, so that then if there is a spike, we're better prepared for that.
Thanks for that, Nikki. Yeah, I think that really sort of pivots even thinking about some of the other things that have been mentioned about, future proofing and sort of how we expand what we have to offer and where it's offered. So I think one of the other questions I'd really like to think you guys to think about is this idea of the strategic national stockpile is, of course, located in just a few places across the country. What would it look like if that model was different? Are there distribution-based or distributor-based stockpiling plans, or some other plan that we could put in place that might be able to be more nimble and supply local needs in a more efficient manner.
One thing I feel that could help with this subject is that there is a supply chain requirement inside of the Healthcare Preparedness Program grants that come out of ASPR. The issue with that is it's not a standardized requirement, where the information that we gather across the country may not match up with from one state to the next, or even one jurisdiction to the next. So if there's a way that we could produce a standardization of information gathering that we have along this, it may help us figure out where we have different gaps and where we see overlap of PPE across the country as this. Thank you.
Thanks, Sean. Other voices about this?
If I could, you know, I think that we need more local and regional stockpiles of PPE, and we probably need to approach it. We can't have these exclusive systems of care. You know, so when we have like different healthcare systems all competing for the same valuable resource, and maybe, you know, I hate to say this, but maybe it's time to bring the accountants into this and talk about, you know, first in, last out sort of stocking. And instead of placing an order to your distributor, you know, you pull out of the cache and then you backfill as you need it. But we need to have some type of dynamic plan where we work together and we don't compete with one another for this resource. And the resource, you know, that when we talk about that cache, it should be available for everybody, because you know, at the same time, you know, I was taking phone calls in my locality regarding, you know, from, you know, these small little group homes, et cetera, about how could they get PPE, and they were truly struggling. So, you know, we have to think in broader terms. Our patient population isn't just, just the patients that we serve in our system. It's the entire community.
Absolutely, yes. And I think, you know, equity has been a big word in all of this planning, and I think it's a great goal and a very difficult thing to achieve. So, yeah, I appreciate that reminder that whether you're in a nursing home or in a personal care home or in a big hospital, or any of the other people who ended up needing PPE, right? I mean, we did need groceries, and we did need other things that became perhaps those critical workers that hadn't previously thought of themselves as critical workers. So we've talked a lot about respirators, and certainly that was a big deal during COVID, partly probably because of this lack of understanding. It seems to me that we have a couple gaps here that I'd like to at least spend a couple of minutes talking about. One is the knowledge gap, right? In order, several of you guys mentioned this, knowing what the hazard is and knowing what to use for that hazard. And I wonder, you know, when we think about whether it's a train derailment or a pathogen event, we have this gap naturally, where we don't always have all the information we wish we had, right? We don't always know exactly what the hazard is or how we need to address it. And I think that sets off then a cascade, in some cases, of mistrust or frustration, right? Why can't you just give us one answer about this, right? And yet that may not be possible at the start. So what would be different moving forward if the threat was different and the advice does change over time? How do we build that into how we respond?
So this is Jennifer. I think some of the things that we've discussed in our health department is really changing the mold or the thought that scientists and public health officials or health officials know it all from the start, right? It's kind of really letting them know that things are going to change. And that's hard for people to always understand and accept, especially when it comes to a high morbidity or mortality type of situation. But, you know, being as honest as we can about the fact that it will change. I also think that something that we need to work on is when we talk about N95s, we talk about fit testing, and then we tell the public that they should wear an N95, and they've never been fit tested. So it's kind of that change of thought process in trying to help our public as well as the healthcare officials and staff of how can we be more proactive, and especially those that are more vulnerable to mortality and morbidity from different situations, and how we can maybe include that as part of the provider assistance that we give to our community members and patients.
This is something that I've written about quite a bit, and I have a lot of thoughts about, but I'll be brief. Is the subjectivity that often comes into these situations is it can be daunting. The reason I say that is all those things that we talked about, knowing what the hazard is, knowing its characteristics, the risk level, knowing the hazard controls that are needed, being able to advocate and educate for those controls. If situations become overtly political, or they become tied to people's, whoever they are on either side of the spectrum, subjective opinions about that, then it can create a challenge. And that's something I was speaking about earlier, is that, if there's misinformation, disinformation about the actual hazard, or if there's subjective advocacy for lower level controls because somebody's subjective opinion is that it's a low risk, and even if there's known information, or if there's a lack of information, to your point, but there's still people pushing for lower level controls just on the hope that the situation is not going to deteriorate, then what happens is, if the situation turns to be more high risk when more research is done, then it's already set a dangerous precedent that those controls are not going to be implemented, and or people are not going to want to use those controls. And there's been a lot of that, even in healthcare environments where people, they haven't wanted to use the respiratory protection, they haven't wanted to get a fit test, they haven't wanted to get vaccinated, in the communities, they don't want to do social distancing, they don't want to use source control. And so if that subjectivity can be relieved, and replaced with valid and reliable research, whatever the best we have at the time, and then using those controls to where we're able to veer toward better risk management, and there can be a consistency and I dare say an agreement, because there'll probably never be an agreement, but more of an alignment across the board. It can take away some of that, those political overtones, and replace that with reliable hazard control. But again, that's kind of my short version. But thank you.
Yeah, thanks, Corey. And I actually want to play off that a little bit to ask Nikki a question, because I think this idea of some confusion, some lack of guidance. Nikki, you mentioned how many questions your company's hotline got about PPE and respirators specifically, I assume. But first of all, do you have any idea of how many calls we're actually talking about here? And then also, I just want to ask, that to me clearly demonstrates that we have a gap in guidance, in understanding, in guidance for use, and in probably things like labeling. If somebody can't clearly see in the product they pick up at the store what and how to use it, how do we address those? So Nikki, I'm going to ask you to sort of, if you know numbers, give them to us, and sort of what your perspective is on that knowledge gap.
Yeah, I don't think I know numbers, but I can tell you that we very quickly not just decided to increase our US manufacturing and manufacturing around the world, but we had to triple the number of staff. I believe it's triple, don't hold me to that, on our technical helpline. Again, these are people trained in health and safety. We have nurses on the technical helpline. We have people from all different types of industry. And each individual can take easily 100 calls a day, if not 200 calls a day. That is in addition to all the calls that just came into 3M. It's hard for people to reach a Department of Health. It's hard for people to reach NIOSH and the CDC and get a live body, but they can call us. Actually, 24 hours a day. Our helpline's only open during work hours, but there are 3M lines that get you to actually me after hours. If you have a real emergency, and I talk to a lot of people, not only during COVID, but when the volcanoes in Hawaii erupted, anytime we have a flood. I've got a chat from Jessica saying about 1,000 calls a day we took, and I know a lot of people did get hung up. So people call because they're confused and they're scared, and there's a 1-800 number on their package, or they can get to it online. And we really try to start with science and talk about the science of eye protection. We make all kinds of PPE, the science of respiratory protection, and be very clear about what the science will do, and then try to talk about the latest guidance that is out there from the US government. So in addition to the people who are answering the phone calls, we have people that basically just scour the websites all day and try to use our connections to get the best information. I think that that's one of the things that we can probably do a little bit better in the future is, really make sure that we're explaining as a community, not just 3M, but as a health and safety community, really explaining to people what is the science behind the decisions. As Jennifer mentioned, being really upfront and honest with people, not trying to, guide their behaviors with suggestions, but explaining the science and the reality of the situation. And making sure people have the information that they need to make the decisions they need, and helping people understand, which is another thing that we did, is helping people understand that there are all different types of personal protective equipment available, not just N95s. And we did a lot of education on what is a KN95. And I think for all of us, again, as a community, to remember that most people are getting their information from the media. And I have heard this from healthcare included. They didn't have time to read endless websites. They didn't have time to read all of the bulletins. They would hear it on National Public Radio driving in, what's the latest. So really making sure that we're also putting out information that the media can easily transmit on behalf of the scientists to people so they understand the latest guidance.
Yeah, I think that's so great. And what a great point to think about, that speaking with a unified voice, right? Whether that's public health, our distributor networks, our manufacturers, and some of the other scientists and hopefully experts within our communities, whether those are people from your medical centers or people from your schools, about what they need and what people should be using. Really great point there. I greatly appreciate. I want to go back to something that we really sort of started off with, and that's when we talked about using things out of the stockpile and using things that have expiration dates. I know that the study that Susan talked about said that there were several devices that were actually quite appropriate to be used past their expiration date. And it makes me wonder, as we think more about the standards that apply here, what does that tell you about maybe that there needs to be a change? Like if you examine a bunch of things and they all work, a year, 2 years, 3 years after their expiration date, well, does that need to be modified in some way that the standard then accommodates that? Or how do we make that system of sort of checks and balances, if you will, of the supply make more sense and be more functional moving forward?
Not to dominate the conversation, but I with regards to shelf life, there is not currently a standard on how a manufacturer determines shelf life. So that's really left up to the manufacturer. And we're not just looking at the filter media, we're looking at, do the headbands say as stretchy on, if they've been stored for 5 years as they would at the beginning. We're looking at, does the nose clip still able to bend? If there's a face seal or foam, is that, is the adhesive still there? So it's not just the filter media, which is what most people focus on. But looking at a standard for how a manufacturer would determine the shelf life, I think might be something, can it be done just on aging testing? Do we actually have to store it for a number of years? Those kind of things would probably be helpful to make sure that as distributors, purchasers, end users look at that shelf life or that, shelf life date, they know that, how much work a manufacturer has done to validate that. And they know then, really that it was done in a scientific way, and that might give us more insight on what the data means, again, as a community, not just manufacturer by manufacturer.
My thoughts about the disposable, filtering face piece respirators is, again, going back to the subjectivity and the reliance on, surface level media versus research and reliability and validity, is that one of the things we've always had to go back to time and time again is that, we'll get calls where they'll say, well, I got this product at this really low price point, or we saw that there was a this got a minute ago as well, that we saw there was a acceptability for KN95s, and so we're going to take that and run with it. And so we would always keep going back to, well, the big thing there is that regardless of whether there's an EUA, regardless of whether it's legally or politically acceptable, it doesn't matter if those respirators either have physical issues like the elastic or the actual face piece material, or if they don't pass a fit test. It doesn't matter if the K95 has an EUA on it. It doesn't matter if they don't pass the fit test with it, because it's still not going to seal. And if the person's exposed, showing their family that there's an EUA is not going to relieve the fact that that person's on a ventilator in the hospital. So again, going back just to make sure that things are reliable and valid is so important. Same thing with the shelf lives. We can say, well, the shelf life's been extended, but that doesn't matter if there's dry rot or if it's got mildew on it because it's been in a Connex. So we just always keep going back to that same milestone, is make sure we're scientifically, ethically, morally, legally correct before we push something forward, even if there is a statement on it.
Yep, I think that's great. And I know we're wrapping up, so I would like to make one point here that I think has been sort of swirling around here, and that's that we really want to make sure that whatever we put in place, however we move forward, that we are protecting first with, if we don't know what the hazard is, we're making the worst case assumption that we are overprotecting, and then we can step down. I think the difficulty of saying, well, maybe you don't need this, and then saying you do need it is every frontline worker's worst nightmare, right? I mean, I can't not tell you the number of times I've been into a room for the third day in a row and suddenly they're on isolation. You think, why couldn't we have thought about that 2 days ago before I got exposed? And so I think really making sure that we're taking action that help protect people's health and well-being, whether that is someone in the home providing care to a loved one, whether that's a teacher providing special education, whether that's whoever's delivering your food, or whether that's your EMS that are responding to your car wreck. All those people need to be protected. I know that we are about out of time. I do want to just say, if you've got one of my panelists has something you really want to get across before we end, now's your one chance, and then we'll try to recap this, of course, at the end of the day.
This is John from Houston. I want to really stress that I think we missed the mark here on who we engaged as SMEs, particularly for this whole warehousing, distribution, that whole piece. Because we ended up taking it on ourselves, and I think that's a terrible tragedy to continue to keep doing. We need to really better engage with the real experts, in particular in managing this kind of inventory piece. We need to get them to the table, and we need to figure out how do we properly train and exercise those components, especially if we're going to contract it out or have the feds contract it out.
Thank you, John. Anybody else?
Jill, I just wanted to say real quick, you mentioned earlier having the stockpile in more places might be beneficial, but I have a slight issue with that, in that we are actually all over the United States, and we can get things where they need to go. It just takes a federal decision to deploy it, and we're not a first response mechanism, so we're a backfill. and resupply when our state and local partners run out of everything, and we can get it there in that kind of a backfill time frame, 24 hours or less. But maybe having regional stockpiles or something that aren't federally governed, where people can draw down on them before they make a federal request or something like that might be beneficial. But we're, if we have inventory and it is needed, then we can get it out upon request and the federal decision to deploy. I just wanted to make that distinction, that more locations isn't really going to change that.
Yeah, thank you. I think that was probably me misspeaking, Susan. I think really I absolutely agree that it doesn't have to be an all or nothing, right? We could have a federal essentially supplier of last resort because we have this strategic stockpile and have
Right.
more stock in localities where that makes sense and that they know what those users need and use on a regular basis. So, all right. Well, thank you guys so much. I really want to thank all the panelists for their remarks, for all of you who entered questions, and I know we didn't get to them all. We are going to take a break. It'll be, I think, a little shorter break than we were planning, just so we could get back on schedule. When we return, we're going to move to the agenda that focuses on sort of the specific individual phases of the supply chain, beginning with the design portion. So what the gaps are there in design and standards, and trying to streamline that process in a way that will contribute to, again, a more resilient and responsive PPE and PPT supply chain. So we look forward to everybody joining us again. That conversation will start again at 12:50, unless someone tells me differently right now. So that's about 27 minutes from now. Oh, no, sorry, it isn't. Somebody help me with my math. It's 17 minutes from now. All right. Thank you guys so much. 12:55, Kelsey says. 12:55, we'll come back. Thank you guys so much. I appreciate it to all of our speakers today. Thanks.